Good morning, and a warm welcome to all those around the world joining us today for Intravascular Imaging Live, our relatively new and exciting live series from CCC Live Cases, broadcasting as always from the Cardiac Catheterization Lab at the Mount Sinai Hospital in New York City. I'm Nitin Barman, your moderator for today's session, alumnus of this lab and current lab director at Mount Sinai Morningside. So today we're really excited to present our third case in the Intravascular Imaging Live case series, and the first to highlight OCT imaging in complex cases. The early feedback on the first two broadcasts has been terrific, with record viewership in both the live and archive forums, highlighting the broad-based interest in this topic. Intravascular imaging, particularly in complex cases, still used only in a minority of occasions. And to whatever extent that occurs due to a lack of familiarity and experience, we hope this series to help change that. So Dr. Kinney and Kisuke will really walk us through the basics and practical points for executing OCT imaging. So with all that said, let's get started. As always, we'd love to hear from you in our interactive chat. So please send us your questions right from the website or on the YouTube channel. I'll be monitoring the chat throughout the session. And please know your participation definitely adds to the value of the program. The full case will be posted on our website, www.ccclivecases.org, as well as on the YouTube channel in the next day or so. So if you're unable to see today's program in its entirety, definitely check it out in the archived form. So we have a great third imaging case for you all today. So without further delay, let me take you to the Cardiac Cath Lab, Mount Sinai Hospital, for today's live case. Dr. Kinney?
Yeah, thank you, Nitin, and good morning to everybody, all our viewers who have, sent us a lot of requests saying that imaging is something that they wanted, so that's where we are. So we are starting. Today's case will be using OCT, so we're going to, I have myself and then Amit Huda, then we have our two fellows who are, this is a new, July, we have a new group of fellows, Akash Patel, and we have Prithvi. And of course, we have Kiski, who will be leading our imaging part with the OCT. Techs are Asif and Hakim, and of course, nurses Will and Halina, who have been helping us during our live cases all the time. So going back to the slides, if you can get the slides. So this is what we just mentioned, nothing to say. So our case, this is a case number 3, who is a 84-year-old female who actually presented a couple of months ago with angina class 3, had a positive MPI, mostly showing inferior apical ischemia. So multiple risk factors: controlled hypertension, hyperlipidemia, ex-smoker, maybe the reason why we see so much calcium in her coronary arteries, and SAQ score of 44, which goes with her symptoms. You can see some of the labs that have been shown there with CRP less than 3 and hemoglobin A1C, which is just about 5.8, good creatinine. So she did have a CTA, which showed a calcium score of over 2700 and 3-vessel CAD on CTA with a echo showing good EF. So medication-wise, her referring physician did get her on good medical therapy and was sent to us. So cardiac cath actually, which was done in June, showed 2-vessel disease, heavily calcified, multiple lesions of the RCA and of the Ramus. LED was okay, I'll show you shortly, with a good EF. So she underwent a PCI of the Ramus, and today we are going to do the PCI of the RCA. So I'm going to show you the angiogram, going to the appropriateness criteria because of their symptoms. Go back to the appropriateness criteria just to make sure that it's appropriate based on the symptoms and based on her she was on 2 medications. The case becomes appropriate for PCI. So now go back to the angiogram. So this is her left system. The Ramus that was intervened, you can see that stent, which looks good. Circ and LED were non-obstructive, but you can see the calcium in the LED territory. Moderate diffuse disease in the apical LED. No significant obstruction there. So Without injecting anything, you can see the tram track calcium in the right coronary artery, which is, this is how we say that it is severe calcium. If you see there on angiography, this is where we are. We have a 6 French Mark Lima guide. So now what happened is, if you see, we thought with the multiple lesions, that is one in the proximal RCA, there is a significant disease. After the RV branch, actually between the two RV branch, there is significant disease, and some disease in the distal RCA also. So we went with the Lima guide, but the Lima guide is almost in that conus. So as soon as we did our first injection, went into hypotension and bradycardia. So we took the guide out. This is a good teaching point also. Then I readjusted the guide, but again goes back into hypotension as soon as we engage, because I think the guide is just facing onto that conus artery. So we decided we are going to change the guide. Though we needed a lot of support, we do not need AL 0.75. We will go with just a simple FR guide right now. I think you can change it.
That's a great case. It's a kind of a bread and butter complex case. It's the kind of case that most of our viewers would probably engage. It looks like the reflux is pretty good, so the hypotension was more related to the tip position, huh?
Yeah, that's what we think. So we gave some, EDP is 12, so a lot of fluids are going in as we speak, because you need a good EDP also. That could be a reason when you give a little bit of nitro with that EDP, they can become hypotensive, but she became bradycardic also. I think it's all related to that guide engaging into the conus. So we will go into the FR. So that's a one good teaching point. Go back to the slides now. So this is what we had shown, our tram track calcium, and those were, angiographically, remember now, nodule is becoming something being used regularly, that when you see a calcific lesion, before imaging was part of our life, the only way we decided it was nodule is we will, as we are doing a calcium modification, the more difficulty we face, we used to think, okay, that is because there is a nodule. But now since we have imaging, we are becoming more alert with that. So I think just with angiography, with that kind of filling defect, we predict that we will see a nodule when we do OCT. So just going to how to prep OCT. So if you see there, right, there is a flush. There is an OCT catheter from the side port, right? So we are going to start showing. So you have to take 100% dye, connect it to the side port. And then what you do is you got to flush it with at least 3 drops of the dye coming out. So if you can face the ceiling camera, Amit is going to show everything step by step. So if you see that right now, can you go to the ceiling camera? Okay, good, excellent. So we have Asif. He's opening the catheter.
So like Dr. Kinney mentioned, you can see the OCT catheter here, and this is the side port. We're going to take some pure contrast in the syringe and we're going to flush it.
So very important, point number 1, 100% pure contrast. Do you have? Give the 100% pure contrast.
I can take.
We are going to take it from the manifold. Okay. So it's taking it from the manifold.
And you remove
Kiski, can you tell us why is it that we need 100% contrast?
Yeah, because this is the Abbott recommendation. So, and it's more high viscosity and less like air artifacts. So they recommend to use the 100% pure contrast.
You understood, because you need have viscosity should be 100%. That is why 100% contrast, so that you are able to see everything well. Yep. So one thing about OCT is that you only need dye. Blood has to be replaced. So that is why the recommendation is 100% contrast, and this contrast goes into the tube there.
And
Good.
like she mentioned earlier, we already flushed it and we could see
Three
few
drops
bubbles
coming.
of,
Yeah.
coming out.
Now, Asif is going to give us a console. This plastic comes in. Okay. So you have to know exactly where. You see that, how his hands are going. Okay, wait. Come here underneath. Come underneath. The ceiling camera is not seeing it. Yeah. Okay, yeah. So the console is coming in.
And this is the sterile sleeve.
So everything is done in a sterile fashion.
Okay. And now we're going to connect the catheter here.
Yes. So that's a way to connect the catheter also. You see that, you leave it there and counter it. So you get in. Now everything becomes automatic. So it will give us a sign that we are ready to go.
Yeah. If you can show the
So
OCT
the monitor
screen.
is now telling us preparing imaging catheter. So it gave us a check mark, dragonfly obstar catheter detected.
Show it. Okay, thank you.
That's second one is coming up, which is saying confirming OCT image.
It's coming soon. And this new device, like Ultron 2.0, has a live view on the OCT screen. So the imager can see the angio also, angio and the OCT screen.
And the
at same
system is
time.
ready.
Yeah, it's ready.
Usually, if we decide that we are going to do the imaging, we have this ready all the time, but we are just showing how to prep. So everything is ready right now. It has been prepped. So I'm going to go up with a guide to do that. So go back to the slide again. Slides. So what we have seen is that live image, enable and stop. So all that can be done. Either the operator can do it or the person who is helping you with the imaging can do that. So we can go there one by one. So this is another console. If you want, we don't use it because we have key to help us with everything. Otherwise you can do the things. So when we are doing the OCT imaging itself, this is a very important point that we are going to talk. There are 4 P's that they talk, that you position the catheter across the lesion, okay? Then you purge the lumen. The 3 drops that we did, you purge it so you see the lumen. Then what you do is we got to give some dye that's called puff, so that the entire the guide and the coronary artery is now cleared with the dyes, so that we know you can see it very well, and then pull back. So that is the time we say image acquisition, and majority of the time you see the pullback mode. The pullback mode that we use is high speed. That mode will give us just a quick analysis. We are not going for high resolution deep analysis. That is the commonest mode that we use. And if you have assist, that is a definite setting that they are used for left coronary artery, which is 4 and 14, and for the right coronary artery is 3 and 12. Today we are using assist. We are going to do 3 and 12. If you do not have assist, you need a 20 cc syringe full of dye and somebody with a good muscle. Your biceps and triceps have to be good, so you can really inject fast. Very, very important is that when you are doing the puff, that is going to tell us, can OCT be done or no? If the lesion is over 90-95%, many times you don't see the clearing of the dye. If something like that you see, do not go ahead and inject. Why? This is what's going to happen. Look at that. Guess what happened after this? Patient went into VFib. So there was some ostial left main that was undiagnosed. The guide catheter went in. No proper flush. When you see a blush like that, you know you have your pads ready. So very important that 4 P's have to be done. One, how you prep the catheter so there's no air. 4 P's have to be done right. When you're trying to purge, if you think you do not see dye clearance, do not inject and go ahead and do OCT. So, of course, this we have gone through, why OCT is better than IVUS. very important is better resolution. It's light. I'm very simple, black and white and color TV. That's all how you remember. And we are using the 36 millimeters per second. Why it is important? The strength is calcium, ISR, and in the setting of ACS, you know whether it is a plaque rupture or plaque erosion. And fibrous cap thickness, calcium thickness. Just remember these important points, because the many times these questions are asked in interventional boards about this imaging. So having said that, now let us focus on with this one. We'll go next. We will go right. Yeah, we'll go focus on the case now.
That was a fantastic walk through the setup and execution. I might add one point about the guide position, not just the guide choice. It's tied to the efficacy, as you explained, but also the safety. So, really the ramping of the injection so that the guide doesn't disengage with injection is critical. And also a lot of times we'll deep seat the guide for the injection and then be prepared to immediately back it out. So there's a lot of kind of active participation with the guide, I would say, more so than with IVUS.
Agree. So now we change the guide, okay? And we are trying to engage with the, now we can go, you can see the fluoro, yeah, good. May not sit, may not give us good support, but.
Pretty decent. Oh.
Yeah. That's the thing about, any questions so far from the audience? Okay.
Yes, actually one just popped up. Nowadays we are using saline OCT. Any comments?
Kiski, tell us.
Yeah. I know that some other centers use a lot of saline injection, but actually the contrast is much higher viscosity, like a better image. And like I saw some paper where saline, but sometimes it has a poor image, like a swirling because of the less viscosity. And the multiple time of the injection might cause some like a complication. That's why we use 100% like contrast imaging. But I know more and more data is coming for the saline injection. So.
And I think it's trying to, oh, go ahead.
No, finish, yeah.
I was just going to say, I mean, obviously one of the limitations is patients with advanced kidney disease, and kind of understanding a modified way to do it is important. But I think in cases where you can use the dye, it's probably best for image quality. That was from Mayank Yadav. Thank you for that.
Okay, some dye. So let's see, we are engaged better. Yeah. Not going? Okay. Yeah. So let us see. I mean, guide has no support, barely sitting at the ostium. Yeah. Again, but still you see that. Are you seeing, can we put the hemodynamics by the side? They can watch. There's still some damping there. The question is which wire we use to do the OCT, If we are able to everything, calcium everywhere. You see that even the wires. Okay, so now this is okay. Get us the, Rota, right? Rota wire.
Yeah.
There you go.
Only other question is, do we use with the no guide support, Rota extra support, we have floppy. This guide is just sitting outside. Okay. We called this as a cliff angioplasty. You understand? It's like you're hanging by the guide is barely giving us any support.
And the imaging element is at the distal radiopaque marker, correct? Nothing beyond that.
Okay, no. I think we did not put the picture of the catheter itself.
And you're exchanging for which wire now, Dr. Kennedy?
It's a Rota floppy wire, but I'm more worried about the guide. You see that? We may have to go back with the right? Lima guide.
Yeah. I mean, that clearly was sitting well in the
Yes,
initial
yes.
picture, but
Okay. I
that's
think
better.
now,
Yeah,
good.
nice.
Now it's better. Okay.
Coaxiality is our friend.
Yes. Okay. Now let us see. Get us the OCT. So he's preparing everything, right? Imaging wise. Is here to say anything? How you prep from your side?
No, prep is perfect. Just make sure this is like 90% lesion, OCT might not close. And the most important point is the third P, just she said, like puff. We should see the, like a good clearance of the blood. If it's not good, we might need a pre-dilatation because most important to get the image. So yeah, but anyway, we can try now.
Okay, now, see, this is a key point. One, will the OCT get into through
Yes.
that significant blockage? And then, will we have a good purge flush? Okay. So you see here, can you show the ceiling camera? It's a short monorail, and this is where it starts imaging. You can see the light, red light.
Can you point out there where the radio opaque markers would be?
Radio opaque marker is here,
Gotcha.
but what we focus on, that this camera which is here should be distal to the lesion.
Yeah.
They could see it, right, on the ceiling camera?
No, it was
Okay.
very, very easy to see, yes.
Okay, okay, good. We are going now. Now hemo, yes, by the side. Despite all that, it's still damped. Now, what happened is because we are using dye, not saline, the images that we get from the saline is not the best. Okay, that is one reason we don't like it. So when possible, it has to be dye. You cannot use side holes, and because of that reason, maybe we are seeing this EKG changes and all that. So what we are going to do is, once we are there, let us see. One, will the catheter go through the lesion? Closer. No.
Yeah.
Not in.
Not the most supportive wire, and obviously
Yeah.
a very short monorail. Would you consider leaving the rota and putting a
Yeah. Get us a
different-
side-by-side wire.
Yeah,
Get us
exactly.
Run through.
Get us another wire. The other thing is we do first round of rota followed by then imaging. And this has happened multiple times because that is what our algorithm says, that if we'll go, now this could be the reason that, remember I was saying, should we have changed to extra support wire? This is a case that we could have decided on an extra support wire. Okay, so run through wire, we'll try on run through wire. If it does not, then we do rotational arthrectomy and then OCT.
Yeah, I think that would have been reasonable. There's an impressive lack of tortuosity for her advanced age. So I think an extra support would have been still reasonably safe, but
Now the guide again is out, but let's engage, let's get this wire. We get us the OCT now.
beautiful.
Let us see. We did not even open the rotabar, right? Okay. Take number 2. If OCT does not go right now, right, on the run through wire, do we still, since the fine cross crossed,
You still use a
We
big
were
burr.
thinking
Yeah.
with the 175 burr.
Yeah, right.
Okay? Yeah. Let us see. You know what I fear? Even if the catheter crosses,
It won't pull back well, right?
yeah, it won't pull back, and we have risk of a VFib then.
Yeah.
What do you
Yeah,
think?
it may be prudent to create a channel. I don't know it's going to change your long-term decision making in terms of length, diameters,
No, I think
adequacy of.
it is telling us, okay, go back to my algorithm, Felipe, put the algorithm up, slide. Okay, give us 175 bar.
Yeah, the fine cross seemed to pass fairly
Yes.
straightforward, especially with the weak guide. So I think 175
So now,
is fair.
okay, flush it, yeah. So now what we'll do is we have to remove the run-through wire, okay, when we are doing rotational arthrectomy. And then after that, I'll take this run-through wire, we'll keep it in the side. We will need it after we do rota. We have the, no, don't put that. No, don't put it like that. Go back, stop the, start from the beginning, yeah. Go to the slide from the beginning, because I want to show step by step.
Yeah.
Ready? Yeah.
Yeah, we have it.
Okay, so this is the algorithm which actually we presented last year at the ESC. Kiski presented in the late breaker in one of the session, management of the nodule. Look, the first thing, when it is uncrossable, remember for us, we already decided based on fluoroscopy, it's severe calcium. So many times your imaging is already telling you it's severe calcium, so you got to consider some kind of atherectomy already. Now whether you do rota or OA, it's up to the discretion of the operator what they want to do. Okay, imaging could have helped to select the burr, but here is an uncrossable lesion, so we are telling directly go to atherectomy. I think that's where we are in this part of the algorithm. So we can go back to, we'll go over the algorithm as we do the case. So this is how it will be helpful for people who are trying to manage calcific lesion, how this algorithm could help them. So we have gone through the rota steps in our other live cases. Good, go, testing. Okay, good. So the question will come, why did we select this burr? Since the fine cross, that is a rule that we follow, that if you have any kind of catheter, which is usually we use fine cross here, that crosses the lesion, then 1.5 or 1.75 burr can be used. If the fine cross had not crossed, then we probably would have downgraded to 1.25. It is telling us the lumen is really small. Yeah, Nitin?
Well, no, I was going to say, I think your EYE OCT, I don't know if there's a similar phrase for that, tells you it's a 4O vessel,
yeah,
in all likelihood. So I think a 175 is less than half the artery size. It's a straight vessel and the fine cross crossed. So all reasonable rationale for a 175 burr.
We call it OCT eyes. That first came up. Yeah, so now you see here what happens is if I'm trying to get into the vessel, the guide is coming out. You see that? So what I'll do, I'll leave it here and do my 3 steps. Move the knob backward forward. And here at the Y connector, backward forward, and then on the dyna, just make a... So it's in the guide. So what I'll do is, as soon as I start, I'm going to come out of the guide. Okay? Yeah, see? So the guide movement did not happen.
You see a little slow heart rate there, yeah?
Yeah. Elderly lady, RCA, severe disease, you definitely need. So now what will happen is, I have to do what is called as a movement of the burr with the dyna. You want to give something? Okay. So this is another thing that we want to teach. On dyna, you see that? He's going to do the brake release and I'm going to move the burr forward. Good. Okay, stop. So now I get enough purchase. Because this is only 9 centimeters here.
And it's important that it's locked while you do that.
Yes.
Seems like it's that initial section is with this guide and a floppy wire might be.
Yeah. Now you start seeing a little EKG changes also. Have 1.5 bar ready, full bar. Because if it does not go, but we are okay, we still have some time. But more important is EKG changes and a little hypotension is. You want to advance the wire further?
Yeah.
Okay, good. It
Nice.
made it. So I'm going to polish here. You see that? So that's done, right? Now what I'll do is we come back, we stop here. Now what we are going to do is do the same thing, Dinah, and we move forward, right? Good.
A great technical example. I mean, it's very easy to get frustrated there
Good,
with a
good.
weak guide and
Okay,
a
ready?
floppy wire.
Good. Yes.
And get the burr stuck by pushing too hard.
Okay, good. So the wire, you see the wire is very distal. We have good wire purchase, which gives you a good support. We finished that first lesion. Now we are at the second lesion, and let's do that. Oh. Second lesion was okay. Now we are going to the third. Do we need to move again? Okay, let's do a little movement. Okay, we are third time, we are trying to get more purchase of the burr. So if anybody has questions how to do this, okay, good, stop. So you see that? You do brake release, which means this wire that is held, the brake holds the wire tight so it's not moving backward forward as I'm doing the rota. You understand? So he did brake release and the knob is tight. So this length is not changed. And then if you see manually, I went forward at the Y connector. This is rota not 101, 105.
Yeah.
Level 5.
Show it the Y connector that was missed before the.
So if you're Y connector, I'm keep moving. Okay, you want to show it again?
Yeah.
Let's finish it, then we will show it.
Yeah, when she's in the artery. Right.
So now you see we went all the way distal. Now this whatever I'll coming back all the way here. Okay. So you see that now we have the full 9 centimeter. So how do I get, suppose we wanted to do PDA, that is the time we have to do it. Let's go fast because she's having ST elevation. Go Dinah. Here brake release. This is tight and this is where I move. You see that? And now I get the entire length. Okay, stop. See,
Perfect.
This length is still there. Okay, we're coming out. Okay, yeah. No, sorry. Okay, start coming out. Get the run-through wire. Get the run-through wire.
Great illustration, Dr. Kinney.
Oh, we have it. Okay. We have to get her STs settled before we can do any imaging, okay? Which we knew when there is a lot of calcific burden, one thing that we do see is a slow flow. That's one. And it could be also because we went with a larger burr.
Yep. The other component there is just length of lesion, and there were several sequential lesions, so the burden was substantial.
Yeah.
Sometimes we'll, I don't know. I think giving sodium nitroprusside here would be reasonable, or
I have a nipride ready.
Yeah.
Will has nipride ready for me, but I'm going to wire quickly with because the two things can happen. When you see ST elevation, as soon as rota is done, right? One, you can take a picture right now. Two things you need to be ready for. One is slow flow. Another one, did we cause a dissection with a large burr? So you cannot do any work on the rota wire. What you need to do is you need your workhorse wire. So few people may go back, change it with a fine cross, but we will use our run through wire side by side. We already have a 3-5 balloon ready. we have a 20 millimeter balloon. If somebody says because long lesion, we want 30 millimeter balloon. In a situation like this, 30 millimeter balloon may not go. That is why I like no more than 20 millimeter balloon. Let's take a picture now. So Amit is actually giving me nitride. It's a tank of nitride that has been prepared. Okay, it's a big tank. Yeah, good. Okay, ready? Let us see. Ready? Good. Go.
1 sec.
Oh,
1 sec.
this is
Sorry,
one
this
thing about the assist, you know.
Assist and like Asif. Press it 1 time. Okay. Sorry.
You're used to the manifold
Believe me.
settings.
Okay, good. Okay, ready? Okay, so this is not
Beautiful.
slow flow, it is just a lot of a burden from the thing. I think we are safe. Let me, you know what, get the STs down and let me give a little bit of, I'm giving a little bit of nitro, okay, and do a little flush of mine. Yeah, it's called as, manual balloon pump, little bit.
A couple other considerations here. I think you mentioned earlier the EDP was okay at
Yeah.
12, and the EF was normal. But if the EDP is higher, obviously, or if the LV is bad, this is obviously when we consider things like support. But certainly, maybe even pre-medicating via the fine cross prior to putting the RotaWire in. You can give a little medication before showering the distal bed with
Okay,
debris.
I think we are okay now. Let us see. If the
Yeah, the
EKG
angio
is
looks
looking
great.
better, everything looking better, because I gave a little bit saline, a little bit of vasodilators, things will settle down. So now we can do the OCT, okay? Why we don't have the pressure?
Flushing
pressure,
saline.
pressure.
Yeah, the saline knob.
No, when I open up, okay. So let us try OCT now.
Yep.
I think what I would do is, we'll do OCT. Normally, the way I like to do is at least 3 runs. One is pre, one is after rota. That is time we decide, do you need any adjunct, atherectomy. In the past, we used to be cutting balloon. Now we have IVL. And other thing was, do we RV, otherwise. So with after rota, we'll do 1. And then after that, plus minus after if you are doing adjunct therapy, or usually after stenting. So since we didn't do pre, we still have maybe 2 more, right? Okay, let's see how this will go through. I would say let's just use hand, because this thing is not giving us a good. No, why we don't see pressure here?
No, I just
Maybe we can show the
You
OCT.
should see pressure when you close it. Not that.
No, when we inject, I understand what you are saying.
Okay.
Thank you.
Okay. So now see, this is what you're doing is purging. So what we do is normally, you see that you have to. Can you see it?
Yep. Can
It's
you check
good?
the path from the guide?
Yeah, and then some dye.
So you repurged with the small
Yes.
syringe.
Yeah. Nice.
Okay, good.
Great clearance. So we are ready.
Great
The
clearance.
setting
So
is good. Like
you want to go?
right?
Start doing this. I'm going to do enable.
Yep. You can.
Go. You do it.
Yeah, I do. Okay.
Okay.
Enable, 1 second. Enabling. 1 second. Calibrating. It said, yeah, seen it. Inject. Yep.
Oh,
You
beautiful.
got a beautiful image.
Why we don't see blood pressure? You should be
Yeah,
seeing
it
pressure.
only comes
No,
from
no,
this,
no, I
yeah.
know.
So now we successfully get the image. So now it's thinking about the co-registration. First, we
And
accept
keep
the
talking
image.
how you do co-registration.
Yeah, sure. Now this is a interface of the
RCA.
co-legislation. First, I confirm. So I select the 2 dots of proximal and distal. The proximal is gonna be the tip of the guide, and distal is gonna be the distal RCA. But you see, this is like long. This come to the pacemaker.
No.
Right.
Yeah. So I will try again. Edit.
No. Give them extra points. Yeah.
Yeah. Here.
That
I
was
just
not the right
edited.
thing, yeah.
Now it's selected the real RCA. So now I can confirm.
So much so for AI.
Yeah, it's AI, but still you need a human eye.
You still need human brains.
We'll still have some jobs.
Yeah,
A couple
thank
of
you.
jobs left.
Thanks so much. So now I confirm.
Good.
Yep. Now we got an image. So now you see that like left panel is the angio, and this white dot is the cross section. Then we see the cross section, and the bottom panel is the longitudinal view. So now I can like move this tag. This is a distal RCA, and now you see even the distal RCA has a concentric calcified lesion.
Wow.
Now come more proximally. Yeah, you see something is protruding. So this white dot has like small calcified nodule. Come more proximally.
Now,
Yeah.
can you see that a little? You have to show them.
Little
You see
cursor
how
on the
a cursor
angio.
that is moving. Yeah. So
Yeah.
now we are in
Here.
that near that RV branch.
Yep.
Yeah.
Now come more proximally. Now
No,
we are
stay
coming
there.
to
Stay
the.
there. Let's analyze that.
Yeah. Now
Did
this.
the rotor do anything?
Yeah. This is our tightest part,
Okay.
and you see the on the right panel and like 9 o'clock, like a shaped calcified nodule. This shape is made by your 1.75 loader. Now we check back and forth. Yeah, this is also like artificial, like a shape. It was a calcified nodule, but shaped by the loader. The surface is shaped. Well-shaped calcified nodule.
Okay. Now,
Yeah.
question is what the audience want to learn. I know we have shaved the tightest part.
Yep.
Go further down. Like, right there. Did the rotor do anything? Does
So
not look like.
this part is like open artery between the first nodule lesion, but
Yeah.
we might have a second nodule lesion more
Yeah, okay,
distally.
okay, go
so
there.
I go more distal.
Okay.
Now
Okay.
come
There.
to yeah, you see-
Yes.
yeah.
Yes.
This is the second lesion, this
Yeah.
white dot. And like 12 o'clock, there's a nodule protruding inside, but the surface is again shaped by the 175 loader. So definitely loader did a great job.
Okay.
Push.
So just let's stop there. So now, is there calcium plate
Okay,
circumferentially at the level of these nodules?
yeah, great point. So at this level, like the other half is no calcium. You see the like no plaque, just the adventitia. So this cross section, we just see the like a 90-degree shaped calcified nodule, but not much calcium plate on this cross section. So I should check the back and forth. Yeah, here, like a little bit more proximal. This is like a well delineated border. This is the calcium. And this is also calcium, but some also might have a lipid plaque. That's why attenuation. This is a combination of the lipid and the calcified plaque. It's not 360.
So the way it is looking to me, looks like we do not need IVL.
Yeah,
We could just do balloon, high pressure balloon and stent it.
Yeah.
What do you think?
yeah. You can show the algorithm later, but it looks like not that 270 calcium anymore.
Keep going down to the distal, yeah. There,
Yeah.
any part you think, the rota there, I think.
So now Dr. Kinney. So now I put the AI calcium detection mode. So this orange line means that AI detected the calcium, and I can see the angle of the calcium. It says 136 degree of the calcium, and it also shows the maximum thickness of the calcium. Actually, this like arrow shows the thickest part of this cross section. It says the maximum thickness of the calcium of this cross section is 0.99. It's more than 0.5. It's thick calcium, but the angle of the calcium is less than 180 of this cross section. So it helps like to like more
Do IVL?
faster
Okay.
identification.
So I need to show one slide. That is a rule of 5. So the rule of 5 of the OCT is that your calcium arc is more than 180. So many places the arc is more than 180, thickness more than 0.5, right? And the length more than 5 millimeter. So I think in many places the rule of 5 is holding true here. So
Yeah.
you're saying, so then let's go back. If we are doing IVL, is it 3.5 or 4?
Dr. Kinney, so let's discuss again. It shows some 180 cross section, but it's not come to the 270 arc of the calcium. So based on our algorithm, if it's more than 270, it's a risk of the stent under expansion.
Understand.
Yeah.
That is only the arc we are taking, right? Okay.
Yeah.
So we understood. Based on the arc, we don't have to do it. But then look at your calcium thickness,
Yeah.
which we never included. But if it is thick calcium, would that include?
Yeah. The point is, this is after the rotor. Yeah, but you're correct. Even after the rotor, still we have some 180 and thicker than the 0.5 millimeter calcium.
Okay, so what's the diameter of the vessel now? There?
Sure. I tried to find the EEL to EL here. I see the EEL to EL. It said 4.2 is the vessel sizing. So it's a 4.2 vessel.
Are you saying that we do 4 or shock wave?
If you want a 1-to-1 ratio, we can do so.
Okay, quickly give it. So what
I think that's
based?
reasonable.
Based on the our algorithm was based on the arc. Okay, but we never included the thickness. So in many places you've seen that arc. Majority of places it's less than 180. Few places it's more than 180. And probably we saw nodule in definite 2 areas, right?
Yep. Flux and meat. Yep.
Yeah. So go back to that algorithm, please. And then how did we select? Because we always should do 1-to-1 because it's low pressure. We are going to do at a 4 atmosphere IVL. Okay. And after IVL, are we going to do OCT again?
Here we can see, confirm the fractures or not. Because so far no fracture, just a shaved calcium.
Oh, where is it? Okay, good. Any questions so far?
Not another question, but we have a shout out from Arun Nagarajan. Hello everyone, good to see the GOAT, Dr. Kinney. I know you view the GOAT as Novak Djokovic, but I imagine that Arun is referring to the cath lab. Big fan from Australia, so watching in the middle of the night there. So that's thanks.
He's always watching us. Yeah.
Yes.
One day we are going to visit. One day we are going to visit Australia to watch Australian Open.
Yeah, right. Yeah.
Right, Nitin.
Yes. I like the IVL idea. I think that while it didn't, exceed 270, there are certain segments. That distal segment to me is bothersome.
Yeah.
The burden, thickness, and length.
And other thing about IVL very important is look here. 4 atmosphere. You see that?
Wow.
Yeah. So we are going it. 120 pulse is there. That's number 1. Number 2, the rotor wire is still by the side. Look at that. Look at that. I think you needed it. Now it opened up. We'll do one more. Give a little breather. Only thing, Nitin, we predict there will be ST elevations if we are not fast in this vessel. So we are going to do 2-2 at a place.
And I mean, you would have probably agree that it wouldn't have been unreasonable to kind of empirically use an NC of 4.0 NC, but I think saving steps is important in these elderly patients. She's had heart block, she's had ST elevation, I think the planning has a value in terms of the efficiency as well.
Let's do one here. Go up. Let us see. I think the biggest thing about what I use imaging is if you have to do IVL, right? It's very important that you do 1-to-1 because it's low pressure, so you want to make sure the sound waves reaches the calcium right. Yeah, there is no disease. So let's go back to where the other places. So give enough breathing time. So hemodynamic wise, we are dealing okay. Okay, good here. And
It's
maybe a couple more pulses at the proximal nodule where we really had a tough time with the rotor. Yes, Nitin?
Especially with the 4.0, this is on the IVL, it's really important to prep it repetitively in between inflations. There's some cavitation that occurs, so subsequent inflations, the sound waves may be less efficacious if there's bubbles that form in the balloon itself.
Okay, go there.
But it looks good. It looks like it's...
Okay. So can we go back to that algorithm, Felipe?
Is the distal
Yeah,
portion
yeah.
of the
I think
balloon
this is
there?
not. Yes, yes.
Yeah,
I'm
full
going to
expand.
go in and do a little bit. Yeah, right there in the center. I think we need to open that better. You see that? Hmm. On the outer surface, look at it. Look like the thick calcium is. Go up once more here.
This is the kind of case you have to ration. You have to ration your inflations across 3 levels.
I know we are 150 already. We have 5 more left. Okay, somewhere here. So we will need a 48 and
That's great.
right, another 18 maybe. What's the length you're getting?
From the OCT calculation, total lesion length is 58. This white line to white line is 58. Yeah, so 48 and 18 will cover.
Yeah, but normal to normal will be 48 plus 18.
Yes, yes. One stent cannot cover the total lesion.
Okay.
And actually, distal reference is actually on the calcium plaque, and lumen 3.0, if 3.5 is okay, like one size up. The mid part is full of vessel, of course, proximal.
This is just, I'm doing cine to show good expansion, which is great. And the way we have done it is good. We did not have any more ST elevation.
Hopefully that
Good, go up here. So this is the last, I think. Go.
hopefully that marginal branch behaves with the stenting. You know.
I want to go a little bit inside, down. So what the recommendation is, let me give you one thing. You see this is how it is. You see a dog bone, right? And when you see the vessel, it's fully expanded, you don't need. There's truly no study so far to show that do we have to give the 120 pulse to the entire vessel, because they say you can still give it. It does not do anything to the so-called normal looking vessel, okay? But ideally, if the dog boning goes and you know you've taken care of that calcium at that level, you're done and you can take it out. So we are now still 10 left. I think we are looking good. We are coming out. Right? Okay.
Yep.
Amit agrees. So now instead of doing an angio, can we save dye and do a quick OCT?
You probably get 2 for 1 there with the.
Yes.
Yeah. I would be still interested to see how the RV branches, or that marginal branch rather.
I mean, so far no EKG changes. Based on that, I think we should be okay. Are we using, okay, distal now?
Yeah, like
Right.
view. Yeah, we can check the path again.
Okay, same. We are in the catheter looking good, little flush.
Yeah, nice clearance.
Oh, beautiful.
Yeah, 1 second. Enabling. 1 second. Deliberating. Yeah, please cine inject. Yes, beautiful image.
And it is enabled for 15 seconds, right, Kisuke? So
Yes.
Yeah.
For
It
newer
allows-
operators, you can kind of go a little bit slower. The steps are really well delineated on the screen.
Yeah. So I do the same step for coagulation, proximal, and distal. Hopefully, yeah. Again, it doesn't show that, so I edit, but it's easy. It's human eye. Grading.
For people who are learning OCT, learn this, steps, co-reg.
Yeah.
It is, everything is self-explanatory, but just you got to know, making sure everything is good. Let us see
so
the
I
thing,
start
and
from
do
the
we do 4
distal.
or
I see
4.5?
some like small calcium fractions here, like 11
Wow.
o'clock.
Yes.
This is post IVL. Yeah, here also some calcium fracture or like some dissection. But anyway,
Let's call it fracture.
Yeah, anyway, it's a good plaque modification.
It's a healthy problem. That means we will have a good
bigger
stent
lumen area.
expansion.
Yeah,
Yes,
like
yes.
multiple calcium fracture here
Yes.
and here and here, like 3 calcium fracture of our tightest spot. Yeah, here. This was our tightest spot previously. Now 3 o'clock is shaved by the loader, and the other half is with some like a dissection.
Now the other half, we think it's dissection because non-calcified fibrous tissue.
Correct. So like between calcium and fibers.
Yeah.
We see a lot of this kind of fractures.
So what we also have seen, why it is important that we need more than 180, closer to 3-quadrant calcium, is that if you have calcium that is 1 quadrant, 1.5 quadrant, and then you see the fibrous tissue lipid on the other side, at the edges we start seeing dissection and what we call microperforation when we do the IVL, which we have shown in many of our live cases. Okay, then exactly let us go where the nodule is, the proximal where the rotor took us a long time.
Yeah,
right there.
Yeah, here.
Yeah.
Shaved calcium and some dissection.
And where's that nodule?
Nodule is already shaved.
Shaved. Shaken and shaved, both. You got that? So now we are ready to stent.
Yep.
So based on this modification, I don't think we should go and balloon it again. What do you think, Amit?
Yeah, I think the expansion looks good. And we were 1-to-1 with the IVL balloon. I think we are good to stent.
What do you think, Nitin?
I agree fully, especially with the expectation of us doing a post-stenting OCT run. So we'll have the opportunity to kind of correct any areas. So I agree fully.
Okay, now give us your diameter. Do we still go 4-0?
Yeah, so the proximal RCA is 4-0 vessel, but if we want to cover from the distal RCA, it's not 4-0 lumen.
It's not 4-0?
I mean, lumen. It start 1 second. So distal lumen is 3-0 lumen. So size up 3-5 or 3-5 for distal stent. But proximal definitely you can put 4-0
So
stent.
then, do you want us to take? We'll take a 3-5-48 first, and proximally we put a 4-0. 3-5-48 first.
Sounds good. Anyway, total lesion length is 59.
Yeah. No, my eyes said we are going to use 48 plus 18.
That's correct.
That's good math.
Yeah.
I think another quick point there is it's important with the overlapping stents to consider where you'll overlap and any side branches. So I think I like that 48. I think 38 might land. I might have done 38-28 originally to save a couple $100, but with the 48 being more expensive, but I think that would land right by that branch.
Yeah. So important points here. I think one thing that we saw is rotational arthrectomy causing slow flow, and the main reason for that was maybe a larger burr that we use. So now see if the second wire is not helping us, if this is not going in easily, right? That's we may need a balloon, or this is where we may need a Godzilla. Yeah, that's the only reason I think. Okay, good.
Nice. Good technique.
Okay. Yeah, so what we did was we oriented the guide better, adjusted the wire so we got more purchase, and then you see my movements, hand movements, so we were able to get the stent down. Don't get too aggressive. If it had not gone, so we're going to remove the rotor wire, right?
Yeah, that's the mantra.
Yeah,
right?
yeah. If it had not gone, other thing was then you pre-dilate, now really pre-dilate, which based on the OCT we had seen, we had a good lumen. This is just the length of the stent that was not allowing it to make a turn. Okay.
Deep breath.
You want to take a cine? Yeah. Some die. Okay. You think, see, 48 is not covering. It is once. Okay. Let's take a cine. Confirm. Go.
Which vendor is that?
This is a Abbott.
Right at the mark of the.
Yeah. I think if I pull back a little bit, then we may even need a shorter stent proximally. I think we are good here. Agree?
Yeah.
Okay. We may not need an 18, maybe a 15. We'll have to post.
I'm at 12
The proximal half will definitely need a 4.0 NC.
Yeah. 4020 high pressure, 30
And
may
Dr.
not
Kinney,
make a
on the
turn.
OCT screen, it shows our measurement in your stent placement. You exactly put our measurement point. This is the distal edge.
Oh, wow.
So yeah,
Wow.
this is the new feature of the Ultron 2.0. It shows the live image and our analysis.
But you know that I did not use your image.
I just confirm for like audience.
I used a KTT brain.
So
Okay,
those brackets are the recommended stenting margins.
Yes, yes, that's what he's saying. Okay, ready?
Yeah.
Wow, beautiful.
Nice.
Okay, so now, actually, what do you think, Amit?
I think 15.
Yeah,
like
15,
you
4
said,
or
should be
15.
okay.
Yeah, that's it. And then,
I might have still said 18 because you have quite a bit of proximal landing zone. I don't know if there's much of a downside.
they have, but it'll be unnecessary full metal jacket. You want?
Okay.
You are both?
No harm in like taking. few
Okay, everybody
millimeters
wants 18. Okay, go, give it to me. They already, fellow has already agreed on 18. Okay. Yeah, no harm. And then get us a post, and then we will do one final OCT. Then we have couple more slides. That's it. Any more questions so far? Because I think algorithm-wise we'll go over it again. Yes.
No, but this has been wonderful. I mean, it really the decision tree at all levels, the thought process, and this is the kind of case that certainly would be encountered on a fairly regular basis almost. Maybe I have one question, Dr. Kinney. Would you do kind of this level of OCT in an RC that was not as large as this one, or would you just kind of modify your injection settings and?
You do have to modify so that is why I think RCA setting is less, and in many times, remember, you don't need to use assist, you can do it with your hand. As long as you know the clearance is good. Yes, okay, go. Right, Kiski?
Yep.
Is there anything else you want to add?
14 atmosphere.
Means if it is a smaller looking vessel, but one thing is for sure, remember that 4-piece, when you purge and later on make sure you see a distal flow, that is the key. If you do not see distal flow, do not inject. That is the learning point from here.
Yes.
Because all you need is one VFib when you're doing OCT, and then, there's a big setback in your mind. I think 4.0 is good. Okay, good. Go up here. So you see that it's the same stent balloon, would not go in. So then we pulled back into the guide, you wrapped it, and then we go forward. You want a 4.5?
No,
4.0. It's an elderly patient, heavily calcified vessel. Let's just be gentle.
I think the MSA will be sufficient.
Yeah. So we are going to post it and then final OCT. So we're not going to do, because EKG is fine. Let's not do. One more picture.
Yeah.
So we are actually, so he said up to the acute angle of the RCA was 3.5. So we will go till there and post dilate. And the distal RCA, we will leave it at 3.5. Kiski, you agree with the plan?
Yeah, so Dr. Kinney, as we showed on the post-loader and the IVL OCT, it shows some dissection of the healthier part. So even after stent, the aggressive valve might cause the injury again here. So risk of the perforation. So your decision follow is like a safe one.
Okay.
Yeah.
That's another important point he's making.
Yeah, this is the dissection after the loader and the IVL. Even after covered by the stent, risk of the injury after the aggressive dilatation. So we don't choose the.
He's warning us that do not go aggressive dilation, then there's a risk of perforation. This is a calcium stent, wire bias.
Not a bias, yeah. Nice.
Okay, now you go up here.
Okay.
Then
Going
I will
up.
go. Yeah.
It'll go further after that.
Yes.
What did
I'm
you
at
deploy the distal
14.
stent at
16.
pressure-wise? 16. Yeah, so
12. Yeah. No. Distal, we always 12, 14. We do never go more than 14 with our stent deployment. If you need, you will post. Now here, he went up to 16, 4016. It looks good, right? Now let me get the wire further down and see if I can get this little bit further down. Like he's saying, he's worried, don't. Go up here. Let's do the proximal. Okay, good. You think we covered the proximal edge? Okay, go up now. There, yes. That's good. We covered the proximal edge. All what I say is that dot has to be at the level of the proximal edge of the stent. So the tapering part of the balloon is outside the vessel. Otherwise, usually a millimeter of the proximal edge of the stent is never dilated, post-dilated. When you do post-dilation, you could have under expansion at that level.
we have I think an observant viewer noted something that I saw too, that there's a little bit damping still of the pressure waveform, a little ventricularized. Do you think that's from the guide, or do you think there's some de novo lesion? I mean, obviously we're going to image again.
Yeah, we will image at that time. I will, so you cannot take the guide out, you know, it's not like IVUS, you can take a guide out and image the proximum. Yeah.
You can never get
It could be there is some disease there, because this has been giving us trouble right from minute one.
Yes, I would agree.
If I cannot get the 402 distal to the acute angle, I think we'll just do the OCT and be done with it. Okay, let's see. No, it's giving me a hard time. So
another viewer was hoping to get your insight on how you manage the distal edge dissection. If you'll, when will you do a prolonged balloon versus another stent?
So on the dissection one, for us angiographically, we say type C dissection, okay, where there is a cap with persistent dye. That is the very old way of deciding. But if you are imaging, we have shown it once, but I don't know if we have the slide here, the arc of the dissection, criteria. It has to be the length and the arc of the dissection. Based on that, you have to decide. Yeah, now, nothing wrong. At any time, do a balloon and see how it looks.
Yeah, you can always start with that for sure. Yeah. And I think with the imaging, I'm sorry.
And the balloon size 1:1, low pressure. Because you don't want to go small balloon, big pressure, and again cause more dissection. And
so another point from the OCT point of view, if you see the medial dissection, it's we call the major dissection, so we should cover by this new stent. So intimal dissection or medial dissection, we can check by the OCT.
It's another value of the imaging is that prior to using imaging regularly, we would make a fluoroscopic judgment as to how to act in that situation, and a lot of times we'd have anxiety that evening. Now with separating the dissections into kind of groups is more helpful. All right.
Okay. Now I may need a second wire to get the OCT down.
Get the fielder wire.
Okay, good. Okay. Get the fielder wire so that we know. Calcium and stent.
Yep.
Okay, good.
Very nice.
Nice. Now it's native.
Here.
Yeah, now.
Yeah. Take 4 Ps.
I'm going to pull the guide out a little bit, okay?
Yeah, I was going to say.
I know, because get a little bit. Yeah, I don't know. Okay, let us see how it looks. Okay, good.
Yeah, actually, okay. Yeah, we can try 1 second.
Are we good?
Yeah, okay clearance, because your guide out a little bit. So,
yeah.
But we can try.
Okay, let me get in a little bit more. Okay, now?
Okay.
Are you happy with the clearance?
Yeah, you can check again. Yeah,
better.
Good clearance.
Okay.
Okay, enabling. 1 second. Okay, bleeding. Yeah, cine, inject.
We don't have this cine, but that's...
good image.
Oh,
Yeah,
why we missed the cine?
We did, but it's okay. We saw the OCT, which was wonderful. We could see that. We see that there was great clearance.
You saw inside. You don't need to look outside. Oh, finally.
I
I was
avoid
like, you could probably pull the pacemaker now.
The AI learned it.
Yeah, so I show you that. So from the distal native vessel, yeah, smooth transition. I detail check the distal edge, where like no malposition and like no flap, no hematoma. There is no dissection. Great position, and come to the proximal part. Good
Let's see that
area.
proximal edge, I
Yeah.
think.
The lumen area is here, like 6.5, like 7, 8, well expanded. And here you see
Wow.
like some eccentric calcified nodule behind, where the cross-section area of this is 8. So it's well expanded. The proximal is more expanded. Now we see the...
10.
The apposition is wonderful here.
Actually, we don't see the proximal edge of stent because it's very long stent. So, but as far as I see, all well expanded and no distal edge dissection. And the MSA is 5.3. This is the distal part, but it's more than 4.5, so it's optimal result.
And the proximal, you're saying proximal edge you could not see?
No,
Huh?
No.
That's surprising because
Actually, the
78 millimeters was reached.
Yes,
Is that,
yes.
Yeah.
because we have extra native
We,
like 20,
we went
yeah,
a little bit distal to get the distal edge.
Yeah,
You want me to do the proximal or leave it? I think we leave it. I
Yeah.
think we did a great job.
yeah, I agree.
Let's be happy with our work.
Like,
Is everybody
yeah.
happy? We do a one final picture, right? And then I show some final slides, right? Ready? Look at that.
Nice.
Let's go back to the slides where we stopped. That was, I think I did not show what the normal, where did I stop? Okay, good. No. Okay. Okay, show the slides there. So this is how I think normal coronary artery should look. And like I say, always keep looking at this so-called normal images. You keep looking, keep looking. So you see that first thing they say is you look for the media where you see a dark band, signal poor, you say that. Intima is signal rich, which means you look at white, and adventitia is in between. So two important terminology we need to understand when you are doing imaging or you want to learn OCT. One is they use the word backscattering, but what it truly means, the light goes into the tissue and the light is reflected back. When that happens, you see it's bright. Then attenuation means, you will hear that, right? You hear a lot of this. Means loss of light, which means the light went inside and the tissue absorbed it, took the light. Okay, that is called as attenuation. So whenever the imaging people are talking, they will say backscatter, attenuation, these kind of things. But for us interventionalists, essentially we are saying, is it calcium, lipid, or it is fibrous plaque? So this is what we have written, and I think why we made it like this is very simple teaching point. Go through this slide and keep looking at this slide, what IVUS looks like and what OCT looks like. So A is a fibrous, you see that it's just fibrous tissue, thick. So when we say high backscattering, which means that it is bright, the light has come back. Low attenuation essentially means that it is not absorbed. That is why it looks like that, bright and white. Then you have high attenuation. High attenuation, when you see, it is lipid plaque. And why I know this so much? Because of the yellow trial. This is what we used to look for when we did OCT in every yellow case, that there is lipid. So there is a brightness is because of the fibrous tissue, and high attenuation because that's lipid. When there's lipid, the light is absorbed, doesn't come back. And so this is how it looks like. And then if you have low backscattering, which means the light did not come back, low attenuation, it's well-defined mark. You see that? That is calcium. So look at how the calcium should look like, which we showed today in our case, that how calcium looks like. And then you understand how much arc, make 4 quadrants, 90 degree, then keep adding 180, then third 3 quadrants, and finally, that's how 360 degree, 270, 360 degree. This is artifact. Very important to understand what is normal looking and what is artifact. So this we saw. Remember, Kiski just told that the blood clearing was not good, incomplete blood clearing, because the guide was not coaxial and not fully engaged. And it looks like there's a dissection. You see that? Residual blood artifact. So do not think that this is blood swirling and that it was not done well. Other thing is, as we're doing, the catheter and the wire movements happen. So in the tortuous vessel, see that catheter wire movement can cause another look that there is another artifact. The most important thing is, if the OCT catheter is very close to the vessel and giving you an idea, look at the star, that it is a thin fibrous cap. These are all artifact. So it is not thin fibrous cap, it is not dissection, this is not dissection or thrombus. So remember these images, go through these images when and if you're doing the OCTs. This we explained, I was supposed to do this beforehand, that Ultron 2.0 software, which they say AI is included, but that AI is using somebody's brain. So that is how it was done. So very simple, longitudinal, cross-sectional. So in the cross-sectional, you see that orange arc, which means that it is calcium. In the longitudinal, if you see orange, that means it's 360 degree of calcium around there. Okay, very simple. So for people who are in the private practice, they want to do something like this, do it, and you understand how much calcium is there, and it was giving you all the numbers, which should be very easy to understand. Kiski, you want to add anything here?
No, it's perfect. But still, we need some human eye to modify it. So it's not full like automated. So
yeah. So what he's trying to say is, like we have seen, what does he say? Go proximal, go distal. When he did that, the line was across because of the pacemaker. So what he's saying is the human interaction and interference is required. So this will help you. It will just augment, it will help you to analyze, but human eyes is still necessary to make the diagnosis when after doing this. So this is the same thing. You see 360 degree calcium around. This is just an example, not our case. Lumen detection and all that. This is the rule of 5 for OCT, which I was talking about. So first one is 50 degree. So the arc of calcium, which has to be more than 180 degree. Then thickness, 0.5. Our thickness was from 0.3 to almost 1 millimeter.
Yes,
so which we are trying to say that it was thick. And then other one that we said was the length. 5 millimeter. Of course, we know our length was very long in this case. So remember this rule of 5, which is very important to understand calcium. So I think today take-home message is how to handle calcific nodule. We went through this, uncrossable. So we directly went with rotational arthrectomy here. So we tried with rotawire, did not do. Then we went on the run through. So the OCT catheter did not go through. So what we did, we went and did the rota. And that selection of burr was based on the experience and using our eyes. So if you had done imaging, okay, and you had seen a nodule, so that is where we are coming, that if your arc of calcium, so you see a nodule and then there is plate of calcium around it, that is the key. And in today's case, we did not see that calcium plate around. What we saw is there's a nodule, maybe some calcium around that nodule, but most of it was fibrous tissue across, and that is why we started seeing the dissection. If we had seen a lot of calcium, which is calcium plate, likely we would be able to see the more of a crack. So why it is important, studies have shown that if you have nodule and you have arc of calcium, risk of suboptimal stent expansion. Risk of suboptimal stent expansion leads to stent thrombosis, which is acute, or long-term restenosis. So if your nodule is there and you have a calcium arc that's more than 270, you were able to do image, okay, and your MLD is less than 1.5, you first have to do rotational atherectomy or OA depending on what you want to do. So what is the difference between the two? If the arc of calcium is 270 or bigger, you need additional atherectomy, which means in this case we use IVL. Okay, if the arc of calcium is small, you do nothing. You can probably just use one device based on what the operator's comfort level is, whether they want to use just OA or RA, or in certain situation just proximal vessel. The IVL may reach there, you just want to do IVL, you can do that because your MLD is more there at the level of the 1.5, but the arc is okay. None, very simple. You can just do OA, RA, and if there is no nodule and there's no calcium, you can just do high pressure balloon and be done. And the rest we did here. Like I said, most of the time you probably need 3 imaging, pre, plus, minus. Then after you've done an atherectomy to decide if you need an adjunct device, and at the end you do after the stent plus minus in between 1. We did 4 total here. So nodule wise there are only 2, eruptive, non-eruptive. Most of the time what we see in our practice is non-eruptive, and I think we have shown you the example today. All the 3 nodules we saw was non-eruptive, which means it is calcium there. Eruptive nodule, if you see here, there is a little disruption, little thrombus, all this thing happens, it's a red thrombus on top of that. So there's a lot written on this, and what is the difference between eruptive nodule, non-eruptive nodule, and most important thing that you have to remember, eruptive nodule is very easy deformable because it's soft. We think it is soft, but what we think is it keeps coming back. So the target lesion revascularization is very high in eruptive nodule. Compared to non-eruptive nodule, very hard, like today. We did Rota, we did IVL, then you saw how difficult it was to get the stent down and all that thing. But you see the final result. Minimum we got 5.5, max we went almost close to 10. So the final MSA is very good and the outcomes are good. That's all you need to remember. And this is a board question also. Difference between eruptive and non-eruptive. Eruptive, easy to take care at the first setting, but lesion revascularization and MACE is higher. Non-eruptive, difficult to take care, but other. This pathophysiology, I think, go through this slide over and over again, but most important is mostly in the RCA hinge point and the shear stress of the vessel when it's moving, the lipid starts there, calcium gets, I think it's a typical example why we saw the nodule, exactly what this is telling us right now. So you have lipid, then calcium, then there's collagen tissue, all that comes together and a nodule is formed. This is based on a lot of the pathology. This is what we published, and based on our own experience we came with that algorithm. So the question always comes, what is the treatment if you see a nodule? So like we have shown, is it shaking or shaving? So we said that if you do shaving with rotational atherectomy, we showed it, nodule is like that sticking, rota will go shave it, or when you do IVL, you have you have the calcium plate and the nodule there, you are shaking it around. Both of them work, but many times you need adjunct like we showed in that case. First you do rotational atherectomy, then you do IVL after that. So of course, these guidelines, we have went through this in the past. IVUS and OCT both have made it to the guidelines level 1, mostly for complex lesions. And what they talk, anatomically complex lesion is true bifurcation, long lesion, and this was a long lesion, so definitely a complex lesion. So the saying is that use imaging to understand, but more important is your final MSA is the one that predicts your outcome. We have apps for both IVUS and OCT. Please download it. All that I have discussed is in there, and there are more cases you can go through. Like I said, lot of images. Keep going through the images, learn the images, and that's how you become a master in imaging. This is just the that is saying. So last we are going through 3 quiz. Okay, each cross section represent a fibrocalcific plaque. Select the image considering treating with arthrectomy. My fellows here, what is A, B, which vessel we think we should do arthrectomy? Where do you see calcium? Good. So you see that 5, right? Our rule of five works there, and look at the thickness, the calcium, and the arc. Everything is beautiful. Then which of the OCT image represents a calcific nodule? I think this is Asif can answer this. Okay, Asif said D. Good. That's beautiful. So that is non-eruptive calcified nodule, and B is eruptive nodule. You see a little bit irregular and all these things. And the final one will be, this is a little complicated. You see that the 54-year-old male CAD, and then what happened is presented with non-STEMI. The patient has been fully compliant with dual antiplatelet therapy. Based on the OCT image, you see that, you see what the angiography shows like, right? And then there is an OCT image right there. So our different, what does the OCT image show? Is it a calcific nodule, plaque erosion, stent thrombosis, or spontaneous coronary artery dissection? Yeah, it is more important, it's red thrombus, not white. Okay. That's where we are. So this is the apps now. We know that. Download it and keep learning more. Okay. Thank you. And we are done with the presentation for today. Yeah. You have to add anything?
No. You summarize it really well. And it's a really good thing to learn for everyone to how to do OCT.
Yeah, incredibly illustrative, instructive first OCT case. Thank you. Demystified it, I think, a lot. Just the setup. I think this was a great case to illustrate those things. And I would put a plug for the app, really to look at the images. You mentioned that. That's really the key, is to understand it. I think that's what limits people a lot, is setting it up, executing it, but also understanding the images. So well done, Dr. Kinney.
Okay, Kiski really has to say something.
So the one point that Dr. Kinney did great today's case is we didn't stick to the initial OCT. We tried to close, but it didn't close. We tried the power wire, but it didn't close. And she stopped to start the loader. We didn't stick to the push it. Sometimes we can do like a forcefully push that, and it like a stuck, and it's gonna cause another like a nightmare. So like do OCT safely. That's the point. So
yeah. Okay, great point, Kiski.
Great point.
Yeah. Any other questions from the audience?
No, I think that should probably wrap it up. Wonderful case. Thank you, Dr. Kinney, and to all the members of the Cath Lab team. Really appreciate what you guys did, and thanks to you all for joining us today for this exciting case. The recording of this case will be archived on ccclivecases.org later today. So if you didn't get all of it, you can go back, or if you want to review some things. Intravascular Imaging Live will occur every other month, and we will let you know about upcoming cases by email.
October will be October 3rd.
Exactly.
Isn't it a Friday? Yeah.
That is right. The
October
next IVI live case will be Friday, October 3rd at 8 a.m. Thanks for joining us today, and have a great weekend.
And please send us messages. What are the kind of cases that you would like to see? So we will have it ready and teach you around those cases.
Yeah, great point. Excellent. Great work, everyone. Thanks. And
thank you. Bye-bye.
Have a great weekend. Bye-bye.